Our mystery guest for today is Dr. Edwin Seet, who is Senior Consultant Anaesthesiologist. Dr. Seet is also the Adjunct Associate Professor of Yong Lu Lin School of Medicine. Hi, Dr. Seet.
Hi, very good morning, Michelle.
Good morning. Thank you so much for joining us. Okay, Dr. Seet, maybe you can start off by telling us what do you do as an anesthetist?
Yeah, sure. The anesthetist is a British term. The Americans call us anesthesiologists. So essentially, we are perioperative physicians and we take care of the patients during the perioperative period. In the pre-op period, we'll take a look at the patients, make sure they are fit for the surgery, evaluate them, re-stratify them, and sometimes we have to optimize them. Our main job is actually during the operation, when we look into all aspects of patient care, make sure that the heart is okay, the lungs are okay, brain function, kidney function, they're all taken care of. If the patient is under general anesthesia, we ensure that the patient is not aware during the surgery and we take care of the pain issues as well. For the post-op period, our main concern is to make sure that there are no complications from the surgery.
Okay, so we have heard from other specialists on the topic. So what is OSA or obstructive sleep apnea to the anesthetist?
As a snoring problem, but it is not quite so simple. Not all patients with snoring have clinically significant obstructive sleep apnea. Conversely, not all patients with significant OSA present to us with a snoring problem. So OSA really is a problem with breathing during sleep, where the upper airway collapses when the patient is asleep, preventing essential oxygen from going into the patient's lungs. So OSA is considered mild if this happens on an average of 5 to 15 times per hour, moderately severe if it's 15 to 30, and severe if it's more than 30 times per hour.
So can you share with us what are some common symptoms that patients may have to suspect that they may have OSA?
The patient may complain of daytime sleepiness, fatigue, memory loss, and poor concentration. If he or she has a bed partner may report loud snoring, observe episodes of airway obstruction, choking, gasping, and even restless sleep.
How common is OSA actually?
Michelle, it all depends. OSA can be mild, moderate, or severe, depending on the number of times patients experience upper airway obstruction per hour. A diagnosis of OSA is made when there are more than 5 episodes per hour with some of the symptoms I just described. Patients with really severe OSA can have more than 100 episodes per hour. If you do the math, this means that the patient has airway obstruction more than once per minute with a drop in oxygen level. So going back to your question, mild OSA can be very common. In the general population, it can occur as frequently as 1 in 3 persons. Moderate to severe OSA can be considered as clinically significant obstructive sleep apnea, where doctors are more concerned. When we consider significant OSA in the general population, it is estimated to be as common as 1 in 8 males and 1 in 20 females. As you can see, OSA is more frequently detected in males compared to females.
Now for the interesting part. How about in surgical patients? How common is OSA in patients coming for surgery?
Any patient presenting for surgery can have OSA. OSA is more common in certain surgical groups, including ENT patients, bariatric surgery patients, or patients coming for weight reduction surgery, joint arthroplasty patients vis-a-vis total knee replacement or hip replacement surgery, and major surgery. From the scientific literature, the prevalence of OSA in these patients can be as high as 80%. We did a large multinational study published in the Journal of the American Medical Association about 3 years ago, where we found that as many as 2/3 of patients more than 45 years of age coming for major surgery have unrecognized OSA. Of these 2/3, half of them have significant or moderate severe OSA. That statistic is extremely worrying because unrecognized OSA may lead to increased incidence of post-operative complications.
Oh, those numbers are pretty scary. Okay, so what did the study show?
Because it was a fairly large-scale study of more than 1,200 patients involving several countries, including Hong Kong, Canada, Malaysia, New Zealand, and Singapore, the results of the study were featured in several international media outlets, also in our Straits Times and local Zaobao. So we reported that patients with severe form of OSA were more than 2 times as likely to suffer from serious cardiovascular complications or heart complications after the surgery compared to those patients without OSA. These patients were also more likely to die. Yep, I know it's very worrying, but to die within 30 days after surgery.
But why was that so?
You know, anesthetics given to patients for surgery tend to worsen obstructive sleep apnea because it aggravates the upper airway obstruction. The tongue is more lax or laxer and it tends to fall backwards. This leads to a decrease in oxygen level in the blood and can cause stress to the heart and other vital organs. Furthermore, patients with OSA are known to have a history of other medical problems such as hypertension, ischemic heart diseases, heart failure, diabetes, and even stroke. All this increases their risk for anesthesia and surgery.
Are there any other reasons why you would be concerned about surgical patients with OSA as an anesthetist?
I'm glad you asked. Yes, in fact, there is. Anesthetists often have to place a breathing tube in the patient's throat to assist patients in their respiration during surgery under general anesthesia. This process is critically important for the safety of the patient. Our analysis of the database that I mentioned to you just now showed that patients with moderate to severe obstructive sleep apnea were 4 times more likely to have difficulty in placement of this life-saving tube under general anesthesia. What this means for the anesthetist is that he or she must be so much more vigilant during the process of GA.
Why do OSA patients have a difficult airway?
I'm glad you asked. The same reasons why patients have obstructive sleep apnea are the reasons why the breathing tube is difficult to place. Usually, patients with OSA have a smaller jaw and more restrictive facial bony structure, and also more soft tissue in the mouth, the throat area, and around the neck. This makes upper airway obstruction more likely, and it also makes placement of the breathing tube more challenging with less space to maneuver.
Okay, so I can see it is important to pick up patients with potential OSA before surgery. How do you detect patients with OSA before the operation?
Michelle, the simplest method to use is a bedside test called the Stop Bang questionnaire. This is an 8-point screening test which can be done in less than 3 minutes. Stop Bang stands for S for snoring, T for tiredness during the day, O for observed obstruction during sleep by a bed partner, P for high blood pressure, B for BMI more than 35, or actually in the Asian population, some say 30 would be more appropriate, A for age more than 50 years of age, N with a neck circumference of more than 40 centimeters, or this amounts to a shirt collar size of 17.8 inches or more, and G is gender male. There are several free online calculators that you can use on the internet to assess your Stop Bang score. A score of 3 or more puts you at risk of obstructive sleep apnea. I would be worried if you have a score of 5 or more, because this will put you at high risk of OSA. If the screening test is high, sleep medicine doctors or ENT surgeons and other specialists can order more sophisticated tests to diagnose OSA. This ranges from a wristwatch type oxygen saturation monitor overnight, home sleep studies, or even formal overnight sleep studies or polysomnography, which can be done in the hospital.
Oh, okay, now I get it. I read somewhere that the Stop Bang questionnaire was first created or first designed for the purpose of anesthetists doing the pre-op screening. Yeah, is that right?
Yeah, thanks for asking that question. Stop Bang was first described in 2008 by Professor Francis Chung from University of Toronto. I had the pleasure of working with her for 1 year in 2008 and 2009. So she was the so-called inventor of the stop band questionnaire. Right now, it's probably the most used questionnaire, a bedside tool by all anesthesiologists and other doctors as well.
Yes, I think we should all thank her profusely for creating this wonderful tool that makes it so much easier for us to do the preliminary screening for OSA patients, yeah? Oh yes, so what can anesthetists do to reduce the risk of OSA during the surgical period?
Michelle, firstly, screening is important so that the diagnosis can be made subsequently, or at least for us to have a high index of suspicion. Some patients may benefit from CPAP. CPAP stands for Continuous Positive Airway Pressure. It is delivered using a small device through a face mask. Special drugs should be administered perioperatively during the operation. This includes shorter acting anesthetic agents with less of a hangover effect and minimizing opioids use, such as morphine. High-risk patients may have to be monitored for breathing difficulties in high dependency units after major surgery or invasive surgery.
Can patients with OSA go home after surgery, or do they have to be observed in the hospital for a longer period of time than others?
Yes, selected patients with OSA can go home. Not all patients need to be monitored in the hospital. If the patients do not have serious medical conditions associated with the OSA, if they do not require high doses of pain medication such as intravenous morphine, or if OSA is already well treated with CPAP therapy, these patients can be discharged. These patients really should resume their usual PAP devices that they have been on for OSA. It is important to use these after the surgery whenever they are sleeping. Patients should try not to lie flat on their backs. If possible, lie rather on their side. I would advise to minimize opioid medication as these suppress breathing and worsen upper airway obstruction. And for the first week after the operation, caregivers should watch over these patients more closely.
Okay, so just for clarifications, because I think not all listeners may know what is classified as opioid medications, do you think you can elaborate on that for us?
Yeah, sure. So opioid medication, common ones are morphine, oxycodone, even codeine at high doses. These are all considered opioid medication.
Thanks for elaborating on that. So I hope it's clearer now to those who are listening in. Okay, before we end off today's session, Dr. Seet, do you have any other advice or summary comments which you'd like to share with us?
Yes, Michelle. Again, thank you for having me today. It's been nice to be here. My last piece of advice is that OSA is an important consideration and concern for patients coming for surgery. So we should anticipate when patients are suspected to have OSA. Stop band questionnaire is easy to do, and as I mentioned earlier, takes less than 3 minutes and should be done for all patients coming for surgery, so that we can anticipate problems and act proactively to make sure that the patients are taken through safely through the process of surgery and also into their recovery period.
Okay, thank you, Dr. Seet. Thank you so much for joining us today. Well, if we have any more questions, you would be hearing from us, and hopefully you can help us out by clarifying or by answering some of these questions that we may have, yeah?
Anytime.